Okay, so it's a great pleasure now to invite Sheila Crowe to the podium. She's a professor in the Division of Gastroenterology and Hepatology in the Department of Medicine at the University of Virginia, and director of the Celiac Disease Center and the director of endoscopy. And she's many interests, but particularly looking at immune and epithelial interactions in inflammatory, infectious, and allergic GI diseases. So who better to talk to us about food-related symptoms?
Well, thank you very much, Robin, for the introduction, and thank you, Amy, for the invitation to participate. I'm not a classical functional GI disorders physician, but given my interests in food intolerances and food allergies and celiac disease, I get to see quite a bit of it, plus I'm a female gastroenterologist. So this is a rather general talk. It won't have as much data as the other talks simply because there's not a lot about food allergies and intolerances on a worldwide basis. However, I think a unifying thing, and I can't speak to my colleagues in different parts of the world, but certainly as someone who's practiced in Canada and the US, the cartoon says, "Did you say this pizza gave you indigestion?" And he's cut out a piece of the table as well as the pizza. But in my experience, every patient with gastrointestinal symptoms assumes that something that they either ate or they didn't eat has contributed to their gastrointestinal problems. And I think that's a pervasive thing worldwide, is that people feel food is good for them in many ways, but at the same time they perceive that there's problems with what they've eaten. This is an overview showing you the different types of adverse reactions to food, which is a global term in terms of just a simple way of saying that there's a bad outcome after you eat something. And you can see that I've grouped them on the left-hand side to those that are immune-based and those that are not immune-based. And their terminology does vary on which side of the Atlantic you practice. But in general, food intolerances in the U.S. are perceived to be those types of reactions that are not immune-mediated. So food toxicity, we've just heard a little bit about that from Dr. Spiller. And related to functional GI disorders, there's two main things to take away from this. A severe episode of a foodborne illness may lead you not to want to eat raw oysters again in your life if you got a very bad case of infectious illness from it. But perhaps the more important one, which Dr. Spiller just reviewed for us, is the entity of post-infectious functional GI disorders. Did I skip something there? Yeah. Pharmacologic food reactions are also important. We don't know how much they contribute to symptomatology in people with functional GI disorders and whether or not there are any differences around the world. This really hasn't been studied very much. This is usually looked at in the context of certain diseases that are perceived to be allergic, such as asthma and various other conditions. But we know that there are a variety of food additives and products within food that induce symptoms on a more pharmacologic basis rather than some of the other entities I'm going to talk about. Physiological food reactions are very important. They are a normal part of our dietary environment, if you can use that word, and some of them are simply behavioral things. When we overeat, we eat a lot of something that delays gastric emptying, promotes reflux. It's not a surprise that someone who goes out to a large Mexican buffet dinner and eats 3,000 or 4,000 calories, that they may not have symptoms relating from that. And that's not unusual, but unfortunately people expect to be able to eat anything and everything and not have any consequences from this. There are some studies to suggest that patients with functional GI disorders are more likely to have food intolerances and pharmacological intolerances, which could include additives in foods. However, these are not very rigorous studies. They're largely observational studies. There are a number of foods, and specifically the FODMAPs that Dr. Talley talked about, that seem to be more poorly tolerated by those with functional GI disorders. We also know from anecdotal and other studies that fatty foods, particularly animal fats, contribute to more symptomatology in those with underlying functional disorders. So again, there may be a basis for these types of foods causing more problems for individuals. And again, the diet around the world, I particularly enjoyed the presentation earlier this morning looking at the differences in India, where the diet is largely vegetable and high in fiber, yet for our patients in the U.S. and in other parts of North America, that we advise for high fiber diets. But I think the caveat is that the insoluble fibers are those that are more poorly tolerated versus soluble fibers. Mechanical problems are also an issue, perhaps less in patients with functional bowel like irritable bowel syndrome. These are often things we counsel our patients who have inflammatory bowel disease to avoid, but there are specific disorders such as people who have gastric outlet problems, gastroparesis, and diverticulitis. This is a good example. The disease of diverticulitis and associated diverticulosis is that the perception by the public and many physicians is that we should avoid fiber, nuts, seeds, skins, all this type of thing, popcorn, peanuts. But actually, there's no data that support that. There are studies that show high fiber, insoluble fiber diets actually delays the progression or gives a better course in terms of advancing diverticulosis. And really the only time to advise patients to avoid these very high residue foods would be in the setting of diverticulitis. But again, perception of what causes problems versus actually causes problems can be different. And I don't know how that applies again beyond Western cultures when it comes to diverticulitis. This is something that's very important, I think, to the group in this audience is the psychological food reactions. And these can be taste aversions, texture aversions, secondary to a traumatic experience when eating. I've had patients who report abuse of their father would make them overeat, and then they'd be so full that they would vomit, and then the father made them eat their vomit. You can imagine what that does to your whole view of food and what you ate at that meal. There are other individuals who have functional GI disorders and body image disorders that are very worried about eating foods that cause them to have bloating or distension of their abdomen. There are conditioned responses. The lab I worked in with Mary Purdue in association with John Bienenstock showed that you can condition allergic responses to food that can relate in pulmonary symptoms as well as gastrointestinal symptoms, at least in lab animals. And there's been studies in Australia doing this with nasal rhinitis showing you can condition an immune response. So there may be conditioned physiologic and immunophysiological responses to food, and eating disorders would fall in this category. I have a personal food aversion, which is purely supratentorial, and that is to mushrooms. I read the story when I was 3 of Babar the elephant, and Babar becomes king, a little-known fact to many of you in the audience, because the king of the jungle died from eating a poisonous mushroom. And according to my parents, from that time onward, I never touched mushrooms, and now I will not eat any kind of fungi. Immunological reactions to food are very important. Food hypersensitivity, celiac disease, and in children, the food protein enteropathies. The incidence of adverse reactions to food is not well known. We know that it's very prevalent. At least a quarter to a half of most cultures where it's been studied will find patients or populations reporting adverse reactions to food that could be as simple as heartburn. With regard to food allergy, which is a very specific entity, the incidence is approximately 1 to 4% in U.S. populations and other industrialized countries. It's higher in children and atopic individuals. This is an increasing prevalence worldwide in developed nations, and there is little data coming from the developing world. GI disorders and adverse reactions to food are synonymous, and irritable bowel syndrome and other functional GI disorders is definitely an area where many of our patients talk to us about what they can eat and what they can't eat. This made the cover of Newsweek, the whole epidemic of food allergy, and it's very prominent in the minds of Americans, certainly in many parts of the world. This is where we see some global variation. This has been studied to a limited extent. For example, peanut allergy, which is a major cause of anaphylactic death due to allergy, is most prevalent in North America, where we have a very peanut based culture in terms of our foods and food products. You can see that sesame is an allergen in the Middle East, which is a rare allergy in North America, and fish allergies are more common in Scandinavia. And some of these speak to what the prevalent foods are, and particularly if they're introduced into the diet early in life. So the risk of anaphylaxis, I've just put this in here, is increasing worldwide, but particularly in developed countries. And it has now taken over in countries like the US, Australia, and Britain as the number one cause of anaphylactic death. It's overcome drug reactions and insect venom as a cause of fatal anaphylaxis. Peanut allergy increasing in prevalence, best, I think, most studied in North America, and it is the most common cause of fatal anaphylaxis in most of the world related to food. The oral allergy syndrome is something else that we're seeing more of. This was reported quite a few countries have reported this syndrome, particularly the Scandinavians have looked at this area, and this has got to do with cross-reactivity between plant pollens and food group antigens. Some of this is just for your information. The crossover with latex and food allergy is interesting because this is one allergy, latex allergy, that's increasing around the world. It's been reported in many countries as we increase the use of latex. And you can see there is cross-reactivity with some of the different rubber protein antigens with different groups. And again, one expects that we'll see an increased frequency of this overlap in terms of the food allergy that's associated with some cases of latex allergy. Lactose versus dairy intolerance, we've heard a little bit about this, and this is something we clearly know there's global variation, and you have to argue that lactose intolerance is really a normal state of being because most of the world has decreased lactase activity as time goes on, and they no longer were dependent on their mother's breast milk. Refrigeration really brought the whole issue of lactose intolerance to the fore. We've already heard about the FODMAPs, and here's what it stands for. And Nick is right, some of the good work has been done in Australia on this topic, and it seems that this may be a factor in many patients with irritable bowel syndrome, and certainly I counsel my patients now to try and avoid these types of carbohydrates in their diets and see if it makes a difference. There's been a great interest to try and look at the relationship of food allergy and irritable bowel syndrome, but the studies are very limited, and many of the studies looked at IgG4, which is no longer accepted as a marker of food allergy by various allergy organizations worldwide. The last slide I'm showing you here before I summarize is a very controversial area. I don't know how many in the audience are seeing patients with not celiac disease. They don't have the intestinal lesion, but they have gluten sensitivity. Show of hands. People seeing gluten sensitivity. It is a growing medical condition. I'll use that term. We cannot define it. There are no markers for this, quote, disease, yet, particularly in the U.S., there's a very big interest that gluten is bad for us, that it may be a false neurotransmitter, that may be how it exerts its ability to cause symptoms in the GI tract, as well as neurological and psychological disturbances. It's almost a fashionable disease. It certainly has given a boost to the gluten-free food industry. People who market it and also those who really need to be on gluten-free foods benefit from this emerging group of patients or consumers who really are looking at this as a cause of their symptoms, and there really is no way, I should say, to study this disorder simply because we can't define the disorder and we have no real markers. Some people have proposed that we can use the anti-gliadin IgG antibody as a marker, but again, it's not perfectly specific nor sufficiently sensitive, and we don't have a gold standard either to compare it to. So this is a schematic diagram taken from a perspective view from Elena Verdu at McMaster, where I trained in Canada, and Joe Murray was another author on this, showing this no man's land of gluten sensitivity between functional GI disorders and what we would consider true celiac disease. So to summarize, food intolerances are commonly reported worldwide, although data for most areas of the world are lacking. Food allergy is increasing in prevalence in industrialized areas of the world. There are personal and cultural beliefs and experiences in food elimination or avoidance, but few studies actually address these issues on a global perspective. And the ironic thing is the imbalance worldwide between the haves and the have-nots and dietary practices. There are many people in the world who just eat whatever is put in front of them. They don't get enough calories a day. Yet, on the other hand, in advantaged parts of the world, we have patients, and you all have them in your practices, who have the ability to have these absolutely peculiar diets. I have a sister-in-law like this who takes 1 million supplements, and everything in PubMed changes her diet depending on the week or the flavor. And they have the luxury to afford to be able to modulate their diet. So I think that's perhaps the biggest thing about the whole aspect of food aversion and elimination. Some people eliminate things from their diet not willingly, but they can't afford to have them. Thank you for your attention.